Hi, good afternoon, everybody. So we are just going to start very shortly, but before that, we're just going to try our system. So can everybody from Facebook can hear us? If you can hear us, please click a like. And on the Zoom, if you can hear us without any problems, you can just type in the chat box to let us know. So we were just going to show you some introductions, slides, and some videos while waiting for everyone to join us. Okay. So we're just going to wait for a few more people to join us in Facebook and in Zoom. So as I said, today we are very proud and honored to have Prof. Lydia with us. I will do a formal introduction about Prof later. But if you have joined us, feel free to join to share this talk to your friends and family so that more people can know more about rehabilitations for the elderly. And anyone that you think that is interested with our talk, feel free to share it with them. So if you have any comments or any questions, feel free to drop it into our chat box in Facebook or in Zoom. Our admin team will pick it up and then we will answer it as soon as possible Q&A sessions. Right. Okay. So there will be just a few more minutes when we're going formally starting the talk, but I think there was some problem with the audio earlier, so we just run through some slides, and then we will start. Prof, do you think you want to check your video for the slide while we're on live, or you okay, or shall we just start?
Hi, Dr. Liew. I think we're okay. I think we will just start when you call for.
Okay, yeah. That's fine. So let's see how many participants. Oh, we have more than 50 now on our Zoom. And let's see what about Facebook. So as I said, for those who are on Zoom as well, feel free to share it on Facebook or any other platform. They don't have to register for the talk. They can view the everything straight away directly once they have the link. We have 26 on Facebook already, so which is very good. So let's give them a few more minutes and then we will start officially. And let's have a third go with the video. Right, okay. So a very warm welcome to all of you who have joined us on this very nice Sunday afternoon in Zoom or in Facebook. My name is Liw. I'm your host for today's event. Can everybody hear me? So I think we can proceed. If there's any problems, just feel free to drop a comment on the chat box so that we can interact with you and we can know what's going on. And so I'm very excited to introduce our upcoming Health Talk series that will run in the coming months on rehabilitation health. This is aimed to help to improve our knowledge and awareness in caring for our elderly. And today is the first episode of our series, the rehabilitations for the bedridden elderly. For information, our talk is also going on live on Facebook through our MNCC account. So feel free to share it out to your friends and family, and we will send the link in our chat box as well. So the Health Talk series is a collaboration between Malaysia Network of Caring Communities and the ReGen's Rehabilitation Hospital. This is a part of a ReGen Rehab Hospital corporate social responsibility initiative, aiming to help the communities in gaining back their function. The 6 talks in this series will be run by Prof. Dr. Lydia and her team, covering all aspects of caring for the elderly, including rehabilitations, mobility issue, prevention of fall, technologies in keeping elderly physically able, how to cope and function with aging spine, and lastly, how to address swallowing issue in elderly. So all these are very important topics that we need to know when we are caring for the elderly. Today's program consists of 10 minutes of introductions, a 40-minute talk, and then followed by a Q&A sessions. So, and again, I would like to urge you to put your questions or a comment on the chat box, and we will pick it up during the Q&A session. During the meeting, please keep your microphone muted at all times, and keep your video or camera off to ensure more stable internet connection. These sessions will be recorded. Your participation in the meeting imply that you are consented for the recording. And this is, I don't know how many times now that I'm just going to remind you that type your question in the chat box or Zoom and Facebook. We will answer the question during the Q&A session. And just a little bit of disclaimer before our talk. I would like to let you know that our MSCC Health Talk is aimed to raise public awareness and promote healthy living. All this information provided is not to replace your doctor consultations. If you have any personal health problem, please do not disclose it here to protect your confidentiality, but consult your personal doctor. Right. So now let us present to you our honorable speaker today, Professor Dr. Lydia Abdul. She graduated from the University of Malaysia with a Master in Rehabilitation Medicine. She also obtained her fellowship in neuromodulations from Harvard University. For those who are familiar with rehabilitation medicine, you will have known Prof. Lydia for her passions and dedications in bringing patients back to their optimal life functions. She is one of the pioneers setting up the ReGen Rehab Hospital, which is a Malaysia's first private rehabilitation hospital licensed by the Ministry of Health Malaysia, providing rehab care for communities in their post-COVID recovery journey, as well as patients who suffer from stroke, traumatic brain injury, and so on. She's now the clinical consultant and chief medical officer in the ReGen Rehab Hospital, specializes in neurorehabilitation. And her key interest is in stroke rehab. She has numerous publications, both locally and internationally. So without further ado, let us welcome Prof. Lydia. So Prof, we will let you take over from here, and over to you, Prof.
Thank you very much, Dr. Liew Yen Eit. Let me just share my slides with you for the kind introduction. Okay. All right. Can you all see my slide? Yep.
Yes, yeah.
Okay. Very good afternoon, everyone. A very good Sunday afternoon. And thank you so much for taking your time today to be in this talk where we're going to be discussing on rehabilitation issues for bedridden elderly. Um, Firstly, I would like to thank MNCC for their tremendous effort in trying to do and champion health education in the community. And my sincere thanks to Dr. Liew Eit for mooting this idea and giving us this opportunity to be part of this wonderful project. So just as a disclosure, I have nothing to disclose. I work in ReGen Rehab, as mentioned. There will be a promotional video at the end, so just a little bit of introduction. So ReGen Rehab, as mentioned, is the joint venture between Kazana National and Select Medical. Select Medical is one of the America leading rehabilitation hospital, and yes, we are the first private rehabilitation hospital, and the purpose of our setup is to fill the gap in terms of post-acute care in our ecosystem of healthcare. Okay, so today I will be speaking on rehabilitation for bedridden elderly, and I try to keep this topic as simple as possible. And in today's discussion, we will look at the following topics. Okay, so first, we have got a bit of introduction. We look at some definition of terms. And then I'll take you through the complication of bedridden and or immobility. We look at what are the rehabilitation approaches that we do, and I highlight some home care strategies. And I will end this discussion by sharing with you two cases. Okay. All right, so we know that prolonged bed rest is bad, but yet it is inevitable, and it is one of the most commonest problem that we have in our society. So patients, they have got disease, they have got comorbidities, they become disabled, okay, and they end up having bed rest. We try to understand some term first before we go on. So these three important terms. First, we look at what is rehabilitation. Okay, so rehabilitation is actually a process whereby the primary purpose is to enable a person to function at the highest possible level with the existing physical impairment. Okay, so a person is considered bedridden if they spend significant amount of their time in bed, and this condition can either be temporary or can be quite a long-term situation. And then we look at the definition of elderly. Okay, all right, so how do we define old? The geriatric population is defined as those above 65, but in Malaysia, we do take above 60 as the older population. So we can divide it into a young old, which is 60 and above, old if they are 75 and above, oldest old if they are 85 and above. So this is basically how we would define the old, right? So is Malaysia aging? I mean, is this situation something that we need to address now? So if we look at our country, definitely life expectancy has increased. For female, it's up to 77 years old. Male is 72 years old. And coupled with reduced fertilities, we are seeing an aging population. So if we look at in year 2020, the percentage of population above 65 is 77%. Therefore, we consider an aging society. And in year 2044, the percentage of those above 65 will be reaching 14%. Then we'll become an aged society. And if we look at the year 2056, 2056, whereby the population will reach 20%, that's when Malaysia will be a super age society. So we need to prepare ourselves for aging population. Okay. So what are the common issues in elderly resulting in them being bedridden? So I'm highlighting the common medical condition that we see in our hospital, in ReGen hospital, that leads to immobility, and take you through. Okay, so we look at osteoporosis, stroke, and frailty in the elderly. So as we know, the physiological changes of elderly patient predispose them to a much thinner bone, whereby it is known as osteoporosis. And because of this, hip fracture are common. So when they have got hip fracture, of course, definitely surgical intervention is very important, because the whole purpose is to reduce the immobility following the fracture. But sometimes, because of their bone quality is quite poor, even though they are surgically fixed, they still need a period of immobility. Okay. Next, we look at stroke. Okay, stroke is a very common condition, especially in our society and as well globally. All right, so the number of stroke, the statistic is actually 1 in 4 adult in a lifetime is estimated to actually get a stroke. So stroke is a major cause of disability in adult worldwide, and it's one of the major cause of bedridden in elderly. So because of the stroke, it reduces the quality of life and it results into a chronic condition. In elderly, frailty is also another condition that we have to also look out for. This is when the elderly patient, they present with exhaustion, reduced endurance, very low physical activities, they get under nutrition. So this is the most vulnerable group that will be susceptible to disability, fall, and be a recipient of bedridden elderly. There are, of course, other causes of immobility, which I don't have time to highlight. For example, like a patient with severe Parkinson, they have got a very aging spine, or because of a very severe stroke, they get into coma. And apart from fracture, they also undergo joint replacement, and they may need just a short period of immobility. Other medical condition, for example, problems with the heart, problems with the lung, or they have got a very severe infection. Anything that result in post-hospitalization, for example, post-surgery, and even palliative, if they have got cancer, terminal illness, these are different causes of immobility. So if you look at the elderly people, they have got multiple risk factors, and they go into this cascade of disability. One thing leads to another. So for example, they have got urinary tract infection, they have got frequent urination, they are not eating well, they become dehydrated, and then their blood pressure is low, then this will subject them to a risk of fall, and then they develop fracture and they become bedridden. So this is something that we need to address. Okay, so if we look at the disability amongst the aging population, it will be in a several domain. That means number one, they're not able to do their activities of daily living, their self-care. Ambulatory difficulty is one of the very common and important one. They can have cognitive difficulty, vision difficulty. Hearing is also a very challenging impairment, right? That can arise for them and impact their ability to perform their personal activities of daily living. So it's a vicious cycle, all right? So we can see that illness or injury will give rise to disability. Disability can result in bedridden. Bedridden, if they're not managed, complications arise, can cause them to have prolonged care. In fact, they can even have several readmission to the hospital. Okay, and this is the vicious cycle. But on the other part, there will be the psychological impact, the financial impact as well as the social impact. The social is, the caregivers, the families who are affected because of this situation. So coming back to bedridden, most often than not, mainly it evolved around mobility issue. All right, so they are confined in bed. So from the acute hospital, they are discharged. Then the carers are not well trained, so they end up to be bedridden at home, and then from there they develop complications. So this is where we need to stop this vicious cycle. So that's where when I discuss with MNCC as part of this health education, is to try to create the awareness of this issue, because we know that this is quite a staggering issues, and we need to create a lot of awareness in this topic. So let's look at what are the rehabilitation approaches. How do we actually manage immobility? So first, rehab medicine. Okay, as a rehab physician, I see a lot of patients following impairment, following illness or injury. About 60% of my patient in the hospital are geriatric patient. Okay, so we provide holistic and comprehensive care, and the aim of rehabilitation, the first one is to prevent complication. Next is to improve the impairments, to limit the impairments, and thirdly is to improve their function as much as possible. Okay, are you all following me so far?
Yes.
So, good. All right. So when we talk about rehabilitation for bedridden, these are the components that we manage in the hospital setup, and some of it definitely we can use it for home care strategies. Okay, so for the medical component, the doctors will look into the illness, medication, do a comprehensive assessment to decide on what sort of rehabilitation is suitable. We make sure that we identify complication early. We look at what are the outcome that the patient will be having, right? The nurses, we look into the feeding, bladder and bowel care, skin care, and assist patient in their personal activities of daily living. The physical aspect of the patient, definitely we look into improving their mobility, prescription of their exercise, if there's any suitable physical modalities that we need to provide to them. For the functional aspect, we look at how we can improve the personal ADLs, what sort of assistive devices that the patient may need. And the last but not least, and this is the most important, is the carer education and training, because this has got to start early, and before the patient is ready for home, we must make sure that the caregivers are properly informed in terms of the continuous of care for the patient at home. So like I said, for us as rehab doctors, we do a very comprehensive from head to toe kind of examination. We look at their vital signs, conscious level, because some bedridden patient may be unconscious. We look at all the system, visual, hearing, musculoskeletal. We do a comprehensive neurological examination to determine whether the elderly patient can actually feel, assess their balance and gait, if they actually can actually stand up, and we determine what sort of functional assessment that we need to do. So for example, this patient has got Parkinson, quite severe Parkinson, where there is issues with balance and coordination. You can see he has got difficulty on his left side, so he is definitely at risk of fall, and by the time he came to see us, he was already immobile, right? So in rehabilitation, we work in a multidisciplinary team. All right, it's not just the doctor working on our own. Our team, very important member. We have got the nurses, we have got the physiotherapists, we have got the occupational therapists, we have got the speech language pathology, speech language therapists. We have got the psychologist. Sometimes we do have the manager that will liaise with the patient. So the most important member of our multidisciplinary team is the patient. All right, so whenever we have got the patient, we will definitely do a weekly team assessment to make sure that the patient goal is being met. And if the patient goal is not met, then we need to relook again at what is the problem. Okay. All right, so that's a little bit about rehabilitation in terms of the concept of how we do things. So now I will discuss the complication for patients who are having immobility or bedridden. So there are 6 problems that I will be discussing. The first one will be looking at skin issues, which is a pressure sore, or we know as the decubitus ulcer, lung infection, pneumonia. The third problem, feeding and nutrition. Fourth, looking at the bladder and bowel. Fifth, we'll look at the blood circulation issues. And last but not least, the muscle and joint issues, which is a big component in terms of the physical aspect of the patient. I will not be able to touch base on every complication, but we'll just highlight the main ones. Okay. So this is an illustration that look at the effect of bed rest on older people, which is courtesy of Isla Bassett in Edinburgh. Okay, so this illustration states that a muscle of complete rest will lose 5% of its muscle strength every day. So if the person has got 3 weeks of bed rest, it's equal to 30 years of aging. And looking at the bone mass in acutely ill elderly decreases at 50 times the normal rate, right? And of course, the skin, the only area where the body skin is designed to bear weight is actually the sole of the feet. And if the older person spends 2 weeks, they can actually develop pressure ulcer, which is actually a very preventable complication. Okay, so now let's look at the problem of pressure ulcer. So pressure ulcer is one of the most preventable complications. All right, we have to prevent it at all costs, because if they develop pressure ulcer, it's going to be very difficult. All right, so pressure ulcer occurs because of prolonged lying in one position. Okay, and it is made worsen with poor nutrition because they don't eat well, their nutrition is poor, the dry and wet skin, and of course when we move them there will be shearing force. So all this contribute to the breaking of the skin. And the skin that is high risk is over the bony areas, and when the person has got pressure ulcer, unless they do not have sensation, it can cause severe discomfort, pain, secondary infection, and leads to a lot of depression. So the dressing can be a very painful situation for the patient. So that's why we need to prevent this at all costs. So this is the picture of a pressure ulcer, which unfortunately we are still seeing in this current day and age, right? So it's stage 1, stage 2, stage 3, and stage 4. So like I said, if they already developed stage 1, we must at all costs prevent it from becoming stage 4. Okay, so the common area if to develop pressure ulcer usually is the bony area, and if they are sitting in the wheelchair, of course it will be at the tailbone, at the buttock area, the shoulder blade and spine, the back of the arm and leg, where they rest against the chair. And if they're lying facing up, or what we call a supine position. The most common one will be the back or the side of the head, the shoulder blade, the hip, lower back or the tailbone, and the musculoskeletal area, which is the heel, the ankle, and the skin behind the knees. I have got the illustration here, right? All the bony areas, the head, the shoulder blade, the elbow. This is the most common area, right? The internal part of the knees and the ankle. So to minimize the risk, 2-hourly turning of position is mandatory. It is very important, okay? And then if they're at home, we encourage them to use the absorbent sheet to avoid the skin from becoming more wet. Cotton is very good as an underlay of soft bedding, definitely not plastic, because that one will promote more heat. And if you want to transfer patient, must try to use a slide sheet so that we can actually reduce the shearing force. And definitely we must try to encourage time out of bed, and we must encourage movement with passive range of motion. So for carer to understand, they must make sure that they know whether the patient has got sensation, look at the mobility, the moisture of the skin, ensure that they can have some physical activities, the nutrition, and to minimize the friction shear. Okay. Air mattress, or we call ripple mattress, is something that you can encourage them to use if they're not mobile at all. And positioning pillow is to help them to change their position and to provide them in a comfortable position while lying in bed. We look at problem 2, which can be a serious problem for those who are bedridden, which is lung infection. Okay, what happens is that in prolonged bed rest, there is changes in the lung volume. There's a lot of secretion pooling or mucus pooling. The lung collapse, and then because of the lung collapse, there's a infection. Okay, so when there's infection, there will full-blown pneumonia. So things that can be the telltale will be fever, if they start having a lot of secretion, and then worst of all, they have got difficulty breathing. Okay, so home care strategy, definitely look into the oral hygiene. A lot of people always disregard this aspect. There's a lot of organism in our oral hygiene that we need to make sure that the tongue is not coated. All right, sitting up, verticalization is very, very important. Okay, we must teach them deep breathing exercise. We must not wait for them to get pneumonia before we actually teach them deep breathing exercise. All right, so this is a geriatric chair that we use in our hospital, which is actually very good for them to be sitting up and do verticalization. So this is what we call a very common technique that we teach our patient to improve on their deep breathing technique. It's called the incentive spirometry exercise. This is where we teach them how to use it, where they learn to inhale and exhale. All right, and the whole purpose is actually to improve on their deep breathing technique, to strengthen their lung muscle, to encourage them to sit up as much as possible. But if they can't, it can also be done lying down. Okay, so we're coming to our third problem. Third problem is with regards to feeding and nutrition. Okay, so just now I saw the chat asking that we look into NG tube feeding. So we know that there are several routes of feeding. The first one, of course, orally without any tube. The second one is using the NG tube, which is a very common one because it's the most easiest one. The third one is using the PEG tube feeding, and last is the IV infusion, like the illustration that you can see here. Okay, so this is the PEG tube. PEG tube is actually recommended if they need a long-term tube feeding, yeah, because NG is not the best way of administering nutrition. Okay, NG tube is where you put the tube through the nose, right, and it delivers the feeding directly into the stomach. All right. So when for carers at home, if let's say the patient is on NG tube, what they must watch out for is if patients start to develop cough or shortness of breath during feeding, they start to have fever, if there is any NG tube that is blocked or dislodged, and when the NG tube is due for change. So you must seek attention of our healthcare providers. Okay. And when you want to give them food, make sure that feed a balanced diet and follow their diet restriction. For example, if it's pureed, blended, mince and moist, geriatric diet, okay, we must ensure that patient has plenty of fluid, all right, if they do not have any fluid restriction. And then we must get them to be fed in a sitting up position, right, to prop them up, and then give them small bite, don't rush, and always offer food in small amount. And if they can chew, make sure that they can chew well before swallowing. Okay. All right. Okay. Now we go to problem 4, which is the bladder and bowel. So one of the problem that we frequently see is constipation. Okay. So to avoid constipation, patient needs to be on regular regime for food and fluid, yeah, if it's not contraindicated. We must have a bowel opening regularly. If they can't, you need to actually do a bowel training So we must make sure that we can teach patient so that they can have a regular bowel habit. Of course, fiber is very important, and if at all these are not satisfactory, then we have to prescribe them with medication to treat with constipation. Looking at the stool is also very important. The color of the stool, the consistency of the stool, because it will indicate some other condition. So for example, if the stool is very, very black in color, the color of your hair, so that is actually not good, because it indicates that there is potentially bleeding from the upper GI tract. Okay, so this would indicate that they may have an ulcer in the stomach, that result in bleeding. Okay, so just remember, okay, black poo, black stool, the color of the hair is not good. Okay, all right. When we talk about bladder, again, like I said, urinary tract infection is very common in bedridden patient, so we need to prevent it, right? We must make sure that they get sufficient fluid, right? Regular emptying, especially if they're on CBD. Make sure that they has a frequent change so that they don't actually soil the underlay, the diapers, underwear, because this can also promote the skin. And we must always monitor sign that of infection. So if they are not able to pass urine by themselves, then they will be on catheter. But if they can, we must encourage them to use urinal. So we can adopt things like bladder drill for our patient, yeah, where we ask them to pass urine in a timely manner. Okay, assistive devices, for example, commode to assist them in toileting, right? Okay, so when we talk about bedridden patient, blood circulation issues is also very important, because when they are not moving, especially over their muscles, the lower limb, their legs, yeah, they can actually have blood clot. Is because their muscle is not efficiently pumping after prolonged bed rest. Okay, so to avoid this, sometimes we do give them TED stocking, so that this will ensure that the muscle can maintain to prevent blood clot from happening. But we must make sure that there's no creases. Yeah, so the size of the stocking must be the right size, and must check for any creases and avoid creases. Okay, we also will teach the carer how to do cough pump exercise, because this is a simple technique that will prevent the complication. Okay, and it also help to reduce tightness of the ankle, what we call a foot drop contracture, which can develop very fast if they do not move their ankle. Okay. Okay, so last is the muscle and joint issues. When the patient is not moving their muscle in any disused muscle, the muscle lose mass and strength. It becomes weaker and smaller. And this problem is also known as sarcopenia. And this can further lead to contracture, whereby the ankle becomes completely stiff, right? And following this, you can actually move it and it becomes a fixed deformity. Okay, so to prevent it, we must ensure mobilization at all costs, either active or passive. Passive is when they can't do the exercise by themselves. We must strengthen the muscle and do stretching. We must advocate positioning, use appropriate support for the limb. We need to use all the positioning wedges, pillows. We must provide comfort. And if they do have problems with stiffness, then we look at how else to aid to relax the muscle. So this is just a short video to show you what is passive limb movement. Okay. Next, we look at the upper limb passive movement. Okay, I hope you're still following me. Right. So the other aspect to pay attention, of course, grooming, basic hygiene, bathing, toileting. We must make sure that they are nicely groomed because it will affect them. Room environment in the house, ensure that the room is air and well lit. And if there is an opportunity to get the sunlight, that's the best. All right. And we must make sure that the bed is easy access for the elderly to actually reach for things, and the whole room need to be kept clean and clutter free. And free from movement from the bed to the bathroom. Getting out of bed is very important. They need to have a good sitting system, like a reclining wheelchair. Transfer technique is actually very important as well. We definitely teach carer how to do the transfer, proper transfer. This is for the safety of the carer as well as the safety of the patient. This is an example of a pivot maneuver. We can also train how to use a transfer belt. All right, this is what is done by the physiotherapists, and if there's also the use of hoist if the patient is it's quite difficult to actually use manually. Okay, so we must never forget the caregivers. The caregivers is very, very important. So we do caregivers training, right? We teach them all aspect of care. For example, this patient is immobile because of the stroke, and we have to teach the husband. So simple things, like I said, transfer technique, yeah, how to handle the patient, right? How to even put the patient sitting up, okay, and transferring to a commode chair, right? So patient is definitely not comfortable because of the ulcer. Okay, so supportive therapy. It's very important for us to give supportive therapy to the caregivers. All right. So this can be accessed at the myhealth.gov.my, whereby some of the information that is provided here is to address some of the emotional and psychological aspect of the caregiver. right? So whenever they come to see us with the patient, we must never forget that apart from the patient, we also have to check on the caregivers. All right, just to summarize a little bit about what we have covered for home strategies, we know how important positioning is. We talk about a lot of movement, passive movement. We emphasize on the breathing. We look at the active arm and leg exercise, emphasize on the sitting, transfer technique, and mobilization out of bed, right? So that is basically some of the strategies that we must teach you. Okay, so as I mentioned, these are the two cases that I would like to share. This lady is 94 years old. She came to us following a fracture. So they did a dynamic hip screw. Following the fixation, she was not allowed to do even partial weight bearing. So she had to be immobile for about 6 weeks before we can actually mobilize her. Okay, but good thing is we did help her to move. So she was very happy. Okay, so they can still move. All right. The next patient is an 82-year-old lady who suffered a stroke. Before she came to us, she was not able to ambulate for about 8 months after the stroke. It also made worse because of the COVID. So when she came to us, we look at her and we saw that she had got good potential, and we managed to actually retrain her again to walk. Right? Okay. Definitely, it has got to be safe first, above all. Okay. All right. So lastly, if there is a need to find placement for patient, like I said, the whole purpose that ReGen Rehab is established is because in Malaysia currently we have got a lot of acute care hospital, and then we have got a lot of nursing home. Some are being regulated, but most of it's not regulated as yet. But the regulation is going to come in place, so there is actually a bubble between acute and post-acute. So this is where rehab hospital come in play, yeah, to provide post-acute care. Okay, so this is where they provide only rehabilitation with multidisciplinary team, medical care, nursing, therapy, step-down facilities, or if you need to choose, must make sure that you choose skilled nursing facilities. Okay, so hopefully with this education, we will definitely help our community to prevent all complication at all costs. So before I end, just a short, not so short video. It's about 2.5 minutes. I think in the interest of time, I will not play the video, but you can just check this on YouTube, all right? So I'm gonna pass back the session to Dr. Liew. So I thank you for your time and your attention. Yep, over to you, Liew.
Thank you, Prof. Lydia. It was a very informative and very comprehensive talk on rehabilitation medicine. So before we start the Q&A sessions, I would just like to remind all our audience and participants today, the slides and the talk will be available on our MNCC website. So we will rearrange all the slides and put some Q&A sessions, questions and answer into the ebook. And then we also will put the recording onto our website so that you can revisit and revise some of the information given by Prof. Lydia today. So we will share the website link to you later on. There's also a link that's been given in our chat box. So don't worry if you have missed any part of the talk or any slides during the presentation. So let's go to the Q&A sessions. So I think we have some questions on our Zoom platform and some on the Facebook platform. So let me start. So the first questions on Zoom is a little bit about consenting and about decision-making issues. So, Prof. Lydia, we have a participant asking, in a later stage of life, if the patient doesn't want to have a tube feeding, do we have to honor their wishes? So this is around decision-making and then shared decision-making. So, Prof. Lydia, would you be able to give us some idea or some comment on that?
Thank you so much for the question. I think it's a very important question. So we need to distinguish the outcome and the prognostication of the patient. In my field, I see patient in terms of rehabilitation with fairly good outcome. So if, let's say, not providing nutrition is going to have a significant health concern, then we will advise against it. However, if the patient is in a situation where it is of a terminal illness, palliative like advanced care planning would come in place. So this is where the consent would be more important in such situation.
Yeah. So I think, as Prof. Lydia said, I think it's very important, and we have to reassess or assess a case by case basis and individualize the care for each of the patients, depending on the risk and the benefit, and also what are the resources available, and we have to look at what is the best interest for the patient. So, and the next questions that we have in Facebook is participant who asked, and the mom is already had back sore, and so moving is very painful, and she's already on morphine. What is the best advice that you can give them, and what's the best way to help them?
Okay, so if they already have the pressure sore, like I said, the pressure sore does need will continue to be treated. Yeah, we can't just not treat the pressure sore, so which means that it still requires daily or may not be daily, depending on the stage of the pressure ulcer. Okay, before the dressing, to reduce the painful and discomfort situation, patient is given already on morphine, like I said. So then that is how it is. Pain control, continue with dressing, and no amount of dressing can actually treat pressure sore if there will always be constant pressure. All right. So even if you give the best dressing, but you are not relieving the pressure accordingly, so it's going to be a continuous perpetual ulcer. So this is where the problem lies. So like I said, this is where if you see a potential patient who is going to be immobile, we need to emphasize and educate to the caregiver, all right, that we at all costs must try to not have pressure ulcer. Okay? And because once the pressure ulcer sets in, it is not just the pain that the patient has got to endure, it's actually the dressing material, and it's a very costly affair. Okay, not only that, they are prone to further infection, sepsis. Yeah.
I think that's a very important concept that, and I think everybody should understand and should learn is, and there's no best dressing for the pressure sore. I think the best thing to learn is how to prevent the pressure sore.
Yeah.
So
that's why I didn't actually go into the dressing. I just emphasized that pressure sore is preventable, and you need to move them, positioning them.
That's exactly. So we also have questions about what types of equipment that the hospital would have for rehabilitation for spinal cord injury.
Okay.
So I'm not sure if there's any specific things they are looking for. Maybe Prof. Lydia can tell us what are the facilities available here.
Spinal cord injury will result in patient having either weakness of both legs or weakness of all limb, what we call tetraplegia or paraplegia. Okay, so when we talk about the basic when we talk about rehab, we provide basic spinal cord rehabilitation as well as advanced spinal cord rehabilitation. So when we talk about basic, again, it is to prevent all the complication because they definitely would be immobile. When we talk about advanced, we're looking at improving the function. So this is where we look into the technology like robotics in trying to make them walk, even though they're not able to walk.
Okay, good. So the other questions is about if they have any mobility issue like bedridden at home, and then we are doing some of the physio or exercise for them. How often do we need to do them?
That's a very good question. Okay, so in general, we would advise our patient to do it 2 to 3 times a day with the duration of 20 minutes per session.
20 minutes per session. Okay. So is there any online guidance or anything that they can follow or anywhere that they can learn it, or do they
Okay,
have
so
to
we do
courses?
have some resources in ReGen Rehab where we have got videos and brochures and pamphlets that we share with our caregivers and patient for them to take away before they go back home. So those are the basic things that that provide these resources. In fact, we can share it on the website, on your MNCC website as well. We're happy to do that. Yeah.
Thank you. So for all the participants, so they, as I said earlier, all the videos that Prof. Lydia showed earlier, if you miss any of them, we will repost it onto our MNCC website. And so feel free to visit the ReGen's hospital website and speak to the part of some of the team members there, and then they'll be able to help you to gain some more information, and you can get some pamphlets and information leaflets from there. There's also one question, does ReGen have any training for any caregiver?
Yes, so it is part of the rehabilitation program. All right, so all caregivers will be given caregivers training.
Good. So I think it's very important as well, isn't it? Sometimes we focus on the patients, but we
always underestimate and neglect the caregivers. But in ReGen, we plan the discharge planning from the very beginning. We identify the carer, all right, and then we will tell them what is the expected journey that he or she will be going through, and then we will also discuss to the extent of care that the caregiver will need to provide to their loved one.
Okay. What is the best way to get referred to ReGen Hospital?
Okay, so you can always contact the hospital, all right? And I think there is a number that you can get from the website, and just call in, and we'll be happy to help you.
Okay, and there's some more questions about the caregiver training.
Mm-hmm.
Is that usually a very long training, and do they need to take leave for those training?
No, because we are the professional team. All right, caregiver training, depending on what aspect that needs to be trained, can take between half a day up to maximum of 2 days.
Yeah.
So even in a patient who will be totally dependent on a caregiver, the caregiver training will take only up to about 2 days in ReGen Rehab Hospital.
So as I explained earlier, so like a lot of cases we have to go case by case basis, and as a medical team, we always individualize care for those patients and the caregiver. So so any other questions? So feel free to pop it onto our Zoom or the Facebook platform, and then we will answer it for you. And then today we are very honored to have Prof. Lydia with us. So
I hope I've managed to impart some basic information on the importance of rehabilitation in care for the caregivers as well as the patient. And the most important thing is actually to prevent complication. That's basically the message to take home.
Yeah. So that's also another question that just came through. So how many times a week recommended for neuro rehab therapy for spinal cord injury on lower limb resulting from
Okay.
fracture?
All right. So, for spinal cord injury, depending on the level of injury, right, and depending on the acuteness of injury, usually the following the acute event, the intensive spinal cord injury will take up to about 3 to 6 months. That means they do rehab every day, especially if they are paraplegic, because we know that they must not be immobilized. Okay. Following that, once they have achieved their goal, so for example, their goal is independent with bed mobility. They can do their own turning, they can do their own sit up, they can do their own transfer, they can do their own car transfer. They are independent. They are independent on their wheelchair, because that's what going to be their main mode of ambulation, right? So all this for a person who is paraplegic can be up to about 3 months, and then we go on to the advanced level that needs to do their whether they are suitable for walking, like simulated walking using any form of robotic treatment. If let's say they are tetraplegic, then it's a little bit different. So it's very individualized depending on what is their goal and what is the intensiveness that the patient need. Mm.
So
But
yes,
aging spine, we will cover it in one of our topic, because I know it's a very important topic. Yeah.
yeah. So stay tuned with our series. Okay, we have a series of talks with focusing on different aspects of the rehab medicine. So let's take the last questions from the floor. This question is about constipation. So the patients have black and hard stool, but the bowel movements are regular. And then they also suffering from some pressure sore at the same time. So is there any advice for bowel movements and if they have ongoing pressure sore around the area?
Yeah. So one thing we need to avoid definitely is diarrhea, because when it is constantly soil, it worsens the pressure ulcer. At the same time, constipation is also an issue. So, for example, patient do not pass motion for up to 5 days. It is not permissible at all. All right. The most we can allow is actually every other day. So we need to look at bowel training regime. Okay. Sometimes what happened is there's a bit of impacted stool, right? That means they do have constipation, they may have impacted stool, we may do some digital evacuation, or we may need to use some laxative depending on what we feel is the problem. Okay. But most important thing is to ensure that the patient is not constipated, which is very difficult, because when you're immobile, your intestine movement is also quite slow, and you don't take enough water, nutrition issues. So all these are vicious cycle.
Yeah. So we have one more question from Facebook. So do a ReGen hospital have any hydrotherapy facilities?
Okay. So that is in the phase 2 of our plan. Currently, we do not have any hydrotherapy that we can offer as a service as yet. Yeah.
Yeah.
There's no aqua therapy yet. It's only land-based therapy.
Right. Okay. So and I think that's the last question we will take from Facebook and Zoom. So thank you very much, Prof. Lydia, for your information and for your time today. As you can see on the screens, I have shared the information on our MNCC website. So that's just another reminder to let you know that we will have the recording and ebook available on our website. And we also will share some of the rehab hospital information on our ebook, so that you can get a link through there to visit and to know more about what are the services and what are the facilities available at the ReGen Hospital. And of course, stay tuned on our Facebook page. Click like and share and then we will update you about our next talk, the time and the link to the Zoom meeting, so that you can join us for the next Rehab Health Talk series. So we also would like you to fill out some feedback forms. So there's a QR code on the slide. If you can give us some feedback on our health talk, if there's anything that you want to know more, or any feedback on how we organize the health talk event, please let us know. So if there's no other comment or any questions, I'm really, really grateful that we have Prof. Lydia today with us. And thank you for your time and effort and to share this amazing knowledge on this Sunday afternoon. So if there's no questions, then we would close the session. Thank you very much, and thank you for attending the sessions. We hope to see you in our next event. So thank you very much, everyone, and
thank you, everyone. I hope I've been able to give some information, and thank you again, MNCC, and thank you, Dr. Liew, for facilitating this session. Thank you very much.
Thank you all. We will see you all soon. Have a great Sunday. Thank you all. Right.
Okay.
So Prof, yeah, so if you have a few more minutes.
All right, so hopefully everything was okay.
Yeah, so Prof, we actually have another link to have a quick chat, if that's okay. I think we will share the link with you.
Okay,
We will close this session. Thank you, Prof.
Bye.
Okay, bye.